And we're live.
Yep. Hi, everybody. Welcome to our second Let's Win Facebook Live chat. I'm here today. My name is Allyson Ocean. I'm a medical oncologist at Weill Cornell, specializing in pancreatic cancer. And joining me today is
Anirban Maitra from MD Anderson. I'm a pathologist by training. I'm also the scientific director of the Pancreatic Cancer Research Center here at MD Anderson in Houston, Texas. The bright sunshine you see outside, that's Houston, Texas. So we're an hour behind New York, and it's really exciting to be here with Allyson discussing early detection of pancreatic cancer.
Great. So I guess I'll start off the talk by explaining a little bit about why we need early detection for pancreatic cancer. So pancreatic cancer, unfortunately, is almost always discovered in its most advanced stage. And that's because symptoms do not happen to a patient until the disease has already spread and metastasized throughout the body. So it's very, very hard for us to detect this disease at an early stage. Many times I see patients that come in and they have been complaining of weight loss or back pain or abdominal pain or jaundice, which is yellowing of the eyes and the skin. Those are probably the most common symptoms that happen in someone who is developing pancreatic cancer. But at the time that those symptoms happen, many, many times when we go try to diagnose the disease, we realize that it is already metastasized at the time that we find out about it. And at that time, it's considered treatable, but it's not considered curable once it has metastasized. And we've made many advancements in treatments over the last decades. However, we still have a long, long, long way to go with treating this better and curing this disease. So I'm going to open up to you, Anirban, about a little bit more about early detection and why it's so difficult.
Sure. I mean, I think as you very correctly pointed out, the vast majority of patients with pancreatic cancer in a center like Cornell or at MD Anderson, that would be about 85% of patients will present with disease that has spread beyond the pancreas, either locally or to organs like the liver. And so they become surgically unresectable. So a surgeon cannot take the disease out. And that significantly impacts in terms of the long-term survival of patients, obviously, even though we have really great therapies and new therapies that are coming down the horizon. But there's no question that not being able to take out the source of the tumor does have an impact on survival. And one of the reasons why most patients present early, in contrast to diseases like, say, breast cancer or melanoma, which is a cancer of the skin, is this is an organ that's deep inside your belly. You can't feel it. And most of these symptoms early on are fairly non-specific. You know, you have this vague abdominal pain, you may have some weight loss. And these days, you know, losing weight is considered great. I mean, you know, hey, you're exercising, you're losing weight, fantastic, wonderful, keep going. And before you know it, you realize, okay, somebody's lost 20 pounds in 3 months, and that's not normal. And by the time patients present with visible signs like jaundice, for example, or severe weight loss or severe back pain that's becoming intractable, the disease is typically spread beyond the pancreas. And so this has been a real challenge in terms of early detection, is because the symptoms tend to be so nonspecific early on. And in contrast to some diseases like prostate or colon or breast, where you have screening tests that are available after a certain age, for example, a PSA test or a mammogram or a colonoscopy. Every American above 50 is recommended to have one. We don't have a screening test for pancreas. There's no reliable screening test at this point that exists for pancreatic cancer. And so pretty much the only patients, most patients present with symptoms, with the exception of very, very rare occasions when somebody, for example, is undergoing an abdominal scan, like a CT scan or an MRI for something totally unrelated. Could be a kidney stone or a gallbladder stone, or they had a car accident and somebody told, the doctor said, let's get a scan done, and voila, there's a small tumor sitting in the pancreas that hadn't yet caused major symptoms. So those are the incidental diagnoses that happen, but typically once you're symptomatic, the disease tends to be advanced in most cases. Okay?
Absolutely. And since we're talking about patients who develop pancreatic cancer, there are certain people who are at risk for this disease. And when we think about screening a population for a disease, we want to think about who's the population who's at risk for this cancer. And there are certain well-known risk factors, and I'm going to quickly review them. And then we're going to talk a little bit about screening, or potentially the potential of screening these patients, these people who are part of these high-risk groups. So we know that family history is an important risk factor for pancreatic cancer. So if a first-degree relative, or there is a history of pancreatic cancer in the family in multiple generations, that's a trigger that you could be at risk. So family history is one risk factor. There are certain genetic syndromes that run in families that predispose patients or people to getting pancreatic cancer, and those are hereditary cancer syndromes. And one of them is well known. It's the BRCA syndrome, or the BRCA gene. If someone inherits this gene, they're at risk for breast cancer, for ovarian cancer, and also for prostate cancer and pancreatic cancer. So those are, that's one familial syndrome that can increase someone's risk for pancreatic cancer. In addition to family history, and in addition to hereditary syndromes, smoking is a well-known risk factor for pancreatic cancer, and smokers have an increased risk. Patients who have diabetes are also at risk for pancreatic cancer. And then people who have pancreatitis, which is inflammation of the pancreas over time, also are at risk. Anirban, am I missing? What am I missing?
Cystic lesions, Allyson.
Right. So some patients have to have tests for other reasons. They have abdominal pain, or they have they're getting workups for other symptoms, and they're found to have cysts on their pancreas. And cysts by themselves are benign lesions in terms of what they are. A cyst is a fluid-filled sac, if you will, a fluid-filled tumor or growth that is benign. However, the cells that line the cyst can undergo genetic changes and become malignant. And so people that have pancreatic cysts need to be followed to see changes in those cysts over time, because if they change or grow, they can that can indicate that they could become malignant, and therefore would need to be biopsied and perhaps removed surgically.
Great. I mean, I think that's a fantastic summary, Allyson. So just, if I can quickly summarize. So basically, family history is one important risk factor. If you have 2 or more first-degree relatives with pancreatic cancer, or if you have a family that has multiple breast ovarian cancers, those families also tend to have a higher risk of pancreatic. But specifically, if you have multiple pancreatic cancers in the family, that's definitely a risk factor. And the more the number of family members, the greater is in the individual's personal risk. Individuals who have these fluid-filled sacs in the pancreas or pancreatic cysts. And then diabetes is a very interesting and complicated risk factor, in the sense that long-term diabetes, if you have diabetes for 20 years, that is a very modest risk factor for pancreatic cancer. It's not really like, tenfold like smoking and lung cancer is. But in the recent past, in the last few years, a very interesting relationship has emerged that I think, we are spending a lot of time studying, and that's diabetes not as a risk factor for pancreas cancer, but as a manifestation of a pancreatic cancer that's not yet been diagnosed. And in particular, newly diagnosed diabetes. So these are not diabetics who have had diabetes for 10, 20 years or even 5 years. These are patients, individuals who have been diagnosed above 50 or 55 with new onset diabetes, never had diabetes before, all of a sudden they develop diabetes. The vast majority of those patients will still have diabetes. Okay, it's important to emphasize that. But about 1% of those individuals with new onset diabetes, the diabetes is actually caused by an underlying pancreatic cancer that has not yet manifested itself with the typical symptoms of pancreatic cancer like back pain, jaundice, weight loss, etc. So it's still undiagnosed, asymptomatic, but the diabetes is the first symptom about of that occult pancreatic cancer that's sitting in the pancreas. So how now do we separate that 1% out of 100 with new onset diabetes that may be having a cancer-associated diabetes from everyone else who has just your usual type 2 diabetes? So there are a lot of studies being done in this regard. The National Cancer Institute has funded a large study across the nation on multiple sites that's going to open up very soon. And we're going to actually accrue about 10,000 individuals with new onset diabetes and follow them over a period of 3 years to figure out how can we find that needle in a haystack, that one person who has diabetes that is pancreas cancer associated versus everyone else. So again, just to emphasize, yes, long-term diabetes is a risk factor, but the new onset diabetes, not so much a risk factor, but a symptom of an undiagnosed pancreatic cancer. In addition, there are, as Allyson very nicely pointed out, there are other risk factors that are known and can actually increase the risk for pancreas cancer if you have something else. So for example, smoking is a risk factor for pancreas cancer. It doubles the risk for pancreatic cancer compared to the general population. But if you have a family history of pancreatic cancer and you smoke, that compounds the risk. So if you have a family history of pancreas cancer, don't smoke. Don't smoke anyway, okay? Don't smoke anyway. But for sure, if you have a family history of pancreas cancer, don't smoke. The other thing I thought it would be worth mentioning here is, so we have all of these risk populations that we have identified. Is there something we're doing about this? And the answer to that is absolutely. Many large centers like MD Anderson, Johns Hopkins, Weill Cornell, Sloan Kettering, and others have what are called high-risk clinics. And if you go to the website and go to the pancreas-specific information page, you will find a link to that clinic. We have one here at MD Anderson. And this is for patients, or for individuals, I should say, who don't have pancreatic cancer at this point, but who may be at risk. For example, they may have multiple family members with pancreatic cancer and they require screening, or they may have a familial syndrome, hereditary syndrome like the BRCA syndrome or some other rarer syndromes that Allyson talked about, or they may have a pancreatic cyst and therefore they need to be followed with imaging studies to make sure the cyst doesn't progress to cancer, because again, you don't want to whack out every cyst that's in the pancreas. The overwhelming majority of these cysts are going to be benign. They're not going to progress to cancer. And having a pancreatic surgery is not like taking off a mole from your skin. This is a major surgery. It's an expensive surgery. It has morbidity associated with it. So you want to make sure that it's only done for cysts that are at high risk. And so very often, if you have a cyst in your pancreas, you'll be followed by imaging tests. For example, endoscopic ultrasound is one imaging test that's done by a gastroenterologist. They put a tube through your mouth and they actually image the pancreas. It's a very sensitive way of making sure that the cyst is okay, it's not progressing. Or they could do regular CT scans or MRI scans. So you might be imaged serially every year or every 2 years if you have a cyst. So there are these sort of high-risk clinics that exist in all the large centers. And if you are at one of the risk factors for pancreatic cancer, you can go to these clinics and you can enroll in these studies that will survey you for the potential for developing pancreatic cancer.
Right. And the reason why this is so important is because if you are at risk and you participate in one of these screening studies, then we are able to follow you prospectively over time for any changes in your body that could indicate or trigger us to get further tests that this could be, worst case scenario, a developing pancreatic cancer. And it's really, really important to know that there are screening studies available in most major cities. I mean, sometimes it's hard when someone doesn't live near a major city to find a screening study for this. But my best advice for if you're in an area that's more remote is to get in touch with a major medical center where they can refer you to a screening study, or perhaps you'll even go take a trip and go there and be followed by them informally. If it's not a formal study, you'll be followed by them to get tests done as needed. And sometimes doctors can, a lot of patients ask questions. Well, how will this be covered by my insurance? How do I know that I can afford these tests? Sometimes we're able to make a case for these tests for the insurance company. We say about family history, and we say about risk factors, etc. And then we say why we think this person needs this test. And a lot of times we get it approved. So I don't want the message to be like, oh, it's not going to be approved by my insurance company. It's not worth looking into because this is not a quote standard screening test. A lot of times we can make cases for these tests to get approved, and they do get approved. I want to circle back on what you said about, Anirban, about what you said about the risk in the new diabetics, in the new onset diabetics. You said the risk is 1%, but if you think about that, that's 1 out of 100 people with new onset diabetes can develop pancreatic cancer. Think about those numbers on a bigger scale, because how many diabetics are there that are diagnosed, you know, in terms of, sorry, I'm just going to turn off my phone because.
Yeah. So while she's doing that.
Think about how many diabetics are diagnosed.
Absolutely. I mean, I think this is one of the reasons why the National Institutes of Health and other foundations, including Lois Garden and Pancreatic Cancer Action Network, are so interested in funding studies that are in the new onset diabetes spectrum, because you're absolutely right, Allyson. 1% doesn't sound, or even if it's less than 1%, it doesn't sound like a large number. But if you look at the denominator, because there are so many adult new onset diabetics, I'm talking about individuals above the age of 50, this could be a conduit into diagnosing pancreatic cancer earlier than it would manifest typically, often by a year or 2 years earlier, because in a substantial number of patients. So no question that this is an important area. What we don't have in our hands at this point are, number one, the tools to say, well, who is that 1% out of 100? And two, which is very important, is the awareness in the general, in the primary care community that this relationship even exists. And that's, I think, half the battle, which is that, again, remember, these are individuals who will not have typical symptoms of pancreatic cancer. They might have some early symptoms, maybe some weight loss, but yet the diabetes is not getting better, which is, puzzling. Why is the diabetes not getting better? If you're losing weight, the diabetes is supposed to get better if you lose weight. So the symptoms are very vague. They are not typical pancreatic cancer symptoms. And many primary care docs don't even know about this relationship. And so I think our first battle is to get the message out there that if you have someone with new onset diabetes who looks quote unquote strange, in the sense, you told them to lose weight, but the diabetes is not getting better. They've lost weight and they're keeping on losing weight, but the diabetes is not improving, or they're not responding to their regular medications, or it's suddenly worsening. At least think about pancreatic cancer. It could still not be pancreatic cancer. I mean, but I think it is something to think about. Now, circling back, I want to just step back for 1 second here and just talk a little bit about does early detection even matter? Because I think there is a lot of nihilism about pancreatic cancer. when you hear about numbers of patients nationally, I'm not talking about the large centers, but I'm talking about the community and small places who should get treatment, should get surgery, but don't because they're quote unquote sent home to get their affairs in order. There is a lot of nihilism about pancreatic cancer, which is really sad. I mean, I think we need to have a positive attitude and we need to have access to the best treatments that are on hand as well as clinical trials. So naturally the question arises, does early detection even matter in pancreatic cancer? I mean, is this just something that, is never going to make a difference? So I would argue to that I think from the data that we have, there's no question that the earlier pancreatic cancer is diagnosed and the lower the stage of your disease, we stage pancreatic cancer from the smallest cancer that's in the pancreas, stage 1, all the way to stage 4 when it has spread through, to sites away from the pancreas like the liver, etc. So the lower your stage, the better is your survival. So there's no question that overall, as you go from advanced or metastatic cancer to localized disease, your survival improves. And in fact, some of the only long-term cures that I know, patients who are alive after, and they're few and far in between, but every year those numbers are going up. But we do see some long-term survivors. Those long-term survivors are all patients who were diagnosed at a point when the disease was resectable, small, and was able to be taken out as a clean surgery. And in fact, the patients, individuals who were undergoing screening tests, for example, and where the pancreas or a lesion was taken out because it was thought to be pancreatic cancer, because of, say, a family history or something, these patients are truly long-term survivors. And so I think there's no question that early diagnosis matters. And especially now, as we are developing better therapies after the surgery, what we call the adjuvant treatments. So, adjuvant therapies are what a patient gets after he or she has a pancreatic surgery. As we are getting better and better adjuvant therapies like vaccines and better other drugs, there is no question that the survival for the patients who undergo resection is only going to improve. So our challenge right now, we have 85% of our patients who are coming in an advanced stage. We need to get that 85% down to 50 or even lower, definitely less than 50. So we want to shift the balance from most patients advanced and few patients resected to most patients resected and only few advanced, so that we can really have an impact on the resected population in the adjuvant setting. So again, I want to reinforce this. Early detection matters. We need to invest in this. We need to work in this area. The second question, I think there was a question that flashed on my screen from one of the viewers, which is, well, early detection is fine, but what about the question of false positives? And I think that's a very, very important question. The reason I think we need to talk about it is it's a bona fide question. Well, why don't we just test for pancreas cancer in everyone? Well, if you're above 50, you're going in, you're getting a PSA test done, you're getting a mammogram done, you're getting a colonoscopy done. Let's just do a test for pancreatic cancer. So the simple answer to that is, fortunately, pancreatic cancer, even though its incidence is still going up, is still uncommon enough that there is a great propensity with the tools we now have for doing a blood test, for example, in the clinic, that the chances of having a false positive are quite high. Not only are we'll get false negative, we will miss the disease early on, but also the chances that we might get something that's false positive, because the markers, the lab tests that we have currently available for pancreatic cancer is very imperfect. Okay, and so you can imagine, if you are a patient or an individual who has not been diagnosed with pancreatic cancer and you're told, you know what, I think you have pancreas cancer, you have basically taken away that person's mental health and basically just, put a huge burden of worry on them. Not to mention that, but also the fact that they'll have to undergo a lot of imaging tests that may lead to nothing. This constant worry, well, do I have pancreatic cancer? So because of this propensity for false positive diagnosis and the fact we simply don't have the tools on hand at this point to diagnose pancreatic cancer in the general population reliably, we are worried about false positive. This does not always, this does also to some extent refer to the patients who are at risk, but certainly in the general population, we are not in a position right now to just screen everyone, because the chances of getting false positives are just way too high. And we are going to burden these individuals with a ton of worry, a lot of expensive imaging tests that are not going to go anywhere. So we are very cognizant about this potential for overdiagnosis or false positives, and are working constantly to come up with lab tests or blood tests that are not only very sensitive in the sense that they will not miss pancreatic cancer when it's there, but also very specific in the sense that when it's not there, it'll be negative. It will not call something that's not pancreatic cancer as cancer. So we need both sensitive and specific tests. And that's why till we get there, and because of the potential for false positives and overdiagnosis, you don't screen everyone who walks through the door, okay?
Right. Okay, excellent point. So let's take some of these questions that have come in, because I think they will lead us to even more information about some of the research efforts in screening. One of the questions that came through early on is, I've heard a lot about the test developed by Jack Andraka. Is this test available to the public? So no, there is not a test right now for early detection of pancreatic cancer, but there are many researchers that are currently actively investigating screening tests, blood-based screening tests, and even urine-based screening tests are going on too. The urine is a filtrate of the blood, so some of the proteins that exist in the blood, the cancer proteins, can be shed into the urine, so patients can give a sample of blood and or urine, and we are able to do research on those specimens to come up with what we call biomarkers. And biomarkers are what we are trying to find in a screening test. And I'm gonna let Anirban tell you mostly about biomarkers, because that's his absolute area of expertise as a pathologist. But a biomarker in layman terms is a marker for the disease. So what is it that we can reliably check on in the blood and reliably test for in the blood that will tell us 100% for sure that this is the disease, and will also tell us that by altering this protein in the blood that we're detecting as the biomarker, by altering it with treatment, that it makes a difference, that we're tackling that and that with treatment, and that it makes a difference. So Anirban, tell me a little bit about, and tell everybody about a biomarker and why this is important in a screening test, and what you know about the early detection tests that are closest to being developed right now.
Yeah, so absolutely. So I think, just take a step back then. So what is available right now in the clinic for early detection in terms of a blood test? The only FDA-approved biomarker, as Allyson said, is a protein called CA19-9 that is made and released into the blood by pancreatic tumor cells. And while it's a great marker when you have advanced disease, it's actually not such a great marker when you have early disease, which is really when you want to catch this disease early on. And so its sensitivity, which means its ability to find pancreatic cancers and not miss them, is only 25 to 50% in the early stage disease, which means that it'll probably miss half to 3/4 of the earliest stage cancers. And that's not a good marker if it's going to miss half to 3/4 of the earliest stage cancers. Vice versa, it also doesn't have a very good specificity. There are many benign conditions, not pancreatic cancer related, that can elevate levels of CA19-9 in your blood. And so again, remember I talked about false positives and overdiagnosis and the incredible worry and anxiety that you can impart to an individual by telling them, oh, you might have pancreatic cancer, not to mention the expensive tests that they'll have to go through if it's a false positive CA19-9. So CA19-9 has issues on both sides. It is also not made by a certain fraction of the population. There's a certain genetic defect that doesn't allow your cells to make and release CA19-9. So you could have a normal CA19-9 and yet still have a cancer. So there are a lot of issues with this marker, but it's the best we have at this point, and it is used in the clinic for somebody who has diagnosed pancreatic cancer to follow these patients. Okay?
Right. I just want to point out that in some of the patients, about 15% of people don't make this marker, as you mentioned. I tend to also check another marker called CEA, which is more of a common marker in colon cancer. But sometimes in pancreatic cancer, the patients that don't make CA19-9 in their blood, they do make CEA, so we can follow that as well.
So a very valid question for those viewing today would be, I keep reading about they found the magic marker. I just read this on NBC. I just saw the CBS. I just saw, Dr. Oz talk about this magic marker or someone in the news. Why don't we have a test? And the answer to that is these are great stories and they're fantastic papers and have been done well, but none of them rise to the level of rigor needed for us to make a clinical decision. Okay, these are research studies. Often they are done in a single institution on a couple of hundred patients, while for us to have a clinically reliable test that someone like Allyson can act on and give a patient treatment or have a surgeon take out the pancreas, you would need a test that has been done in thousands of patients and has said reliably, that test has to say reliably, this person has cancer, this person doesn't have cancer. And no marker in pancreas so far has reached that level of rigor. It takes a few years to do that and thousands of patients. So what does that mean? I mean, does it mean we'll never get there? The answer to that is no. And I think what is now happening nationally through efforts from the NIH, the NCI is, the National Cancer Institute is very seriously invested in this idea of now having this blood test for pancreatic cancer. We've had enough of these studies that seem to be single institution but don't go anywhere. So they have convened all of the people who work in pancreatic cancer biomarkers into a room and said, work together and do a biomarker bake-off. This is kind of like, the example I always give, and many of you probably who see this show, Chopped, it's like you put all the biomarkers against each other in a biomarker show, just like they are having a cooking show. And then the ones that don't make it get chopped, and the ones that look good keep going up to the next level, and then to the next level, and then to the next level, till you have sort of a biomarker champion. And this may not be one biomarker. Very likely it will not be one biomarker, because I don't think any one biomarker will be both sensitive and specific for pancreatic cancer. It'll probably be a combination of biomarkers, and that's exactly why we need to have this bake-off. And so other foundations outside of the National Cancer Institute, like the Pancreatic Cancer Action Network and now Lusgarten as well, are very interested in sort of also having these sort of early detection bake-off studies being done by more than one group, more than one institution, because that's the only way where we get to something that is reliable enough in thousands of patients to catch this disease early, okay? So that's why, even though you may have seen these amazing, news releases about magic markers, they still haven't gotten to the rigor needed for Allyson to have a clinical decision made. Right,
absolutely. And, some of the efforts that I've been working on, as well as other researchers, is what I mentioned previously about the urine detection of pancreatic cancer, urine-based detection. Yeah. So there are assays now, and there are even commercially available assays where patients can submit samples, and we can test them for the most common mutation in pancreatic cancer, which is called KRAS. So if there is KRAS in a cancer cell, then that cancer cell is circulating in the bloodstream, that cancer cell will break down and that KRAS protein will be shed into the urine. And so we can detect this mutant KRAS protein in urine and as a way of detection of a disease. Now, the reason why this is tricky and it hasn't been validated as a a screening test for everybody across the board, wouldn't it be great if we could just submit a urine sample and someone will tell you, yes, you have cancer, no, you don't. The reason why is because of this whole false positive aspect to it, and the tests are not specific enough. But what we're working on with researchers is actually selecting patients that are at high risk already for pancreatic cancer, and then investigating these testing platforms in these high-risk populations, because you're honing in on the people that are most at risk for the development of the disease, and then trying to screen those populations first with these new tests. And then once we discover that it's reliable in the high-risk population, then we have to expand it to the masses and test thousands more people to see if this applies to everybody. And so that's why takes a lot of time, a lot of research dollars to perform these tests. But it is an active, ongoing area of research. So we want people to know that a screening test most likely will be a true test that we can order in the near future. And we're really hoping that in certainly within a few years we'll be able to have something available. But right now we currently don't. So there are a lot of researchers at Hopkins, at MD Anderson, at Sloan Kettering, at Dana-Farber, at all the major cancer centers, Mayo Clinic. They're all working on this specific aspect of screening. So let's take another question now that came up about this is actually relates to the one that was just published and came out of Mayo Clinic. And we all, Anirban and I are colleagues with Gloria Peterson and also with Ken Zarrett. And do you want to talk a little bit about that, about their marker that they came up with?
Sure. So Ken's at the University of Pennsylvania, and again, this is probably one of the most recent high-profile news stories you may have heard about an early detection biomarker. It was featured on many media releases, and again, it's a great story. They actually tested a lot of samples of several hundred, but again, it's the same issue that I previously mentioned, which is that you need to do this in a very large number of samples, and you have to pick this particular marker. This is a marker called thrombospondin 2, and you don't have to remember the name. There's no test here, but it's a marker that was found to be elevated or increased in patients with pancreatic cancer, including early stage pancreatic cancer. And now we'll have to do a comparison of how this works in comparison to other biomarkers that also look very good. And does it improve upon CA19-9, which is the one FDA-approved biomarker that we have? So the goal of all of these biomarker bake-off studies is, can we find a magic combination that will make CA19-9 look really, really good, and in particular will be both sensitive and specific in early stage disease, potentially in disease where the patient has not yet presented with symptoms, okay, where they don't have, even the symptoms of early stage pancreatic cancer. This is someone who is a really, really small cancer that might present in the next 1 year or 2 years. That's sort of our utopia where we want to go, which is to get asymptomatic disease. Because if we can diagnose asymptomatic disease, we are likely to have the greatest impact on survival, better than any drug we have on hand right now. So this is, again, I keep coming back to this concept of biomarker bake-off, and the fact that both the National Cancer Institute as well as foundations like the Pancreatic Cancer Action Network and Lusgarten are really interested in this. In fact, the Pancreatic Cancer Action Network has funded Dr. Zarrett and Dr. Peterson, as well as our institution, and a couple of other places, to actually do this sort of a bake-off in common sample sets from the same patients, and see, again, this sort of chopped analogy, what biomarker will rise to the top and really make sensitive and specific combination with CA19-9. So great, promising data from Dr. Zarrett and Dr. Peterson. Now we are ready for the next step, which is to do this bake-off.
So another question came in about CA19-9. And I want to explain a little bit about it because as of now, the CA19-9 is not a screening test. We only check it when someone has a diagnosis of pancreatic cancer. So the question that came in was, well, how high does it have to be to indicate that you have cancer? We don't want people to check this routinely without a diagnosis of cancer, because it, like Anirban said, there are many things, other things that can cause it to rise, the number to rise, and it not be cancer. So we can't randomly go and check, have internists go and check CA19-9 in blood panels, because that will lead to too many false positives. We will go and chase this elevated marker for whatever reason, and most of the time it will not be pancreatic cancer. So we don't want, that's not what we want to do. The CA19-9 as of now is only a test that is done once a diagnosis of pancreatic cancer is made, and it's being, and I use it to follow patients on therapy. You know, as the marker goes down, that usually indicates that patients are responding to whatever treatment they're on. If the marker starts to go up, we have to think that maybe they're not responding to the treatment they're on, and then we have to take a scan and actually get objective information from a CAT scan or an MRI or PET scan that the disease is getting worse. The number going up is not objective enough to say that you need to make a treatment change. So just to clarify, about the CA19-9. Now, let's talk a little bit about the.
You want to talk about the young onset disease? There was some.
Yeah, that's great. So a question did come through about does this happen? Does pancreatic happen to people in their 20s and 30s and 40s, young onset? And I think when we think about young onset pancreatic cancer, we always have to ask the same questions about risk factors, such as, does this person have a family history? Does this person smoke? Has this person had diabetes and complications of diabetes? Has this person had pancreatitis? When we ask all those questions and the answers are no, 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 then we have to delve deeper. We have to figure out, how did this person get pancreatic cancer? And sometimes, if they're young, they may be the first person in the family to develop this disease. So they may be the index case of the family, meaning that they are the first person it's been diagnosed in, even though the genes of development may exist in their family, it wasn't expressed until now. It didn't occur until this young person got this disease. And so when I say we have to dig deeper, what I mean is we get blood testing, we do genomic testing on the pancreatic cancer itself. We test the genes on the cancer so that we know that, we have an idea of what could have caused this. Was there a genetic mutation that led to the development of this cancer? And why did this happen, other than it being a bad luck reason? Go ahead, Anirban, if you want to add to that.
Yeah, so I think I'm going to put my pathologist hat on for a second, Allyson. And I just wanted to add, number one, that when you have somebody who's in their teens or 20s, or for that matter, anyone who has a diagnosis of quote unquote pancreatic cancer, when we think of pancreatic, when you say pancreatic cancer, we are immediately thinking that this is somebody who has this very aggressive variant that is the most common tumor. I mean, 95 out of 100 tumors in the pancreas will be this aggressive variant that we call ductal adenocarcinoma, okay, which is what you hear about in the press of many celebrities dying of this disease, or this is the disease that we study and are talking about today. However, it is important to emphasize that there are many other variants of pancreatic cancer that arise in the pancreas that are also called quote unquote pancreatic cancer, but they may not be adenocarcinomas. For example, you have what are called islet cell tumors or neuroendocrine tumors. This is a different tumor. This is very different genetics, very different biology, and a very different natural history. And therefore, if Allyson gets a patient with neuroendocrine tumor, she would treat that patient very differently from someone who has an adenocarcinoma. There are other rarer variants, very rare variants of pancreatic cancer that arise in children or teenagers. And again, not to delude you with names, but this is a variant that is very different from the typical adult aggressive pancreatic cancer that we're talking about. So when you hear of someone who has developed pancreatic cancer in their 20s, don't automatically assume that they're talking about the same disease. It could be something very different. And typically, a pathologist will look at the section from that tumor or a biopsy and will say, this is ductal adenocarcinoma or not. That's number one. Mm-hmm. Second, I want to go back to what Allyson said about digging deeper. I think it's very important. So when we take, and this is studies that have now come from the Mayo Clinic, from Dana-Farber, from MD Anderson, Hopkins. When you take unselected patients who are just walking in through the door with pancreatic cancer and you do genetic testing on them, by genetic testing, I don't mean on the tumor. I'm talking about in the blood for hereditary mutations. About 10% of those patients will have a germline, what we call a germline mutation, which means every single cell in your body has that particular abnormality, okay? And so that number, that 10% is all pancreatic cancer walking through the door. If you do genetic testing, which currently is not done for everyone, but we are hoping to get to the point where everyone will get that sort of genetic testing, because even patients who don't have an obvious family history sometimes end up having an unexpected mutation or abnormality in their germline or in the cells in the blood, and then that's something that you need to be worried about if the other family members may have it as well, and therefore you need to make sure they don't carry that abnormal gene. So, but that 10% number can double if you look at pancreatic cancers that arise in patients who are under 50. So if you do know of someone who has bona fide ductal adenocarcinoma, not some variant, but bona fide ductal adenocarcinoma under 50, almost a fifth of those patients, if they're tested, may have a deleterious germline mutation or an abnormality in a gene in their blood. And so that number goes up as you go younger and younger into the age of onset of pancreatic cancer. What does that mean? That means that the incidence of what we call genetically driven cancer because of some hereditary mutation or abnormality is higher in the younger onset pancreatic cancer than those that arise in patients who are 60s or 70s. So which is much more environment related. So it's something to remember that if you have someone who has young onset pancreas cancer, which typically is under 50, that's someone you want to encourage getting germline testing done. And now, there are many, all academic centers have genetic counselors that can help you with the process. There are companies that offer germline testing, and the cost is getting cheaper and cheaper and cheaper. And so this is just something to keep in mind, if not for all patients, at least for those who have young onset pancreatic cancer.
And the reason why it's also so important for us to figure out these germline mutations in the patients, in addition to screening their family members, is that it affects the treatment that they will get for the cancer. Because there are new drugs now that target these specific mutations. And there are chemotherapies that we know work better in, for instance, BRCA mutated cells versus non-BRCA mutated cells. So platinum agents tend to work better. We have PARP inhibitors for BRCA. So all of that's why this is so important. We have more treatments now than we did before. So we have to figure out which of these mutations exists in the bloodline and also in the tumor for the patients so that we can apply these therapies to get the best results in the patients. So a question has come in from Dr. Begg, one of our colleagues. Thank you for asking. A patient has a genetic germline mutated cancer. What should their family members do? So we touched a little bit about this before, but what we want people to know is that if a mutation is detected, that means that the family members can automatically be tested. That they can get tested, and that testing most of the time is covered by insurance, so they don't have to worry about that. But if a mutation is detected in the person who has cancer, then the family members have to get tested if they want to get tested. I mean, most people who I encounter want to get tested because they're concerned for their siblings, and their siblings are concerned, and there's concern for their children to develop this cancer. So the reason for testing them is, like we mentioned before, they can enroll in a screening study, and these people can be followed very closely. They get MRIs and they get endoscopic ultrasounds, and they alternate that. So an MRI is done, and then 6 months later, a endoscopic ultrasound is done, and then 6 months later, an MRI is done. So that way, twice a year, some form of testing is being done for these people who are at high risk of getting pancreatic cancer. And so that's the reason why, if a patient is found to have a germline or a hereditary mutation in their blood, that they need to then have their family members go to the genetic counselor also to get tested. There's another question that has come in about someone who was treated for chemotherapy, and this person was diagnosed at age 48. And it says, my question is, I have a 15-year-old son. When should he be evaluated for pancreatic cancer? So my first question to this person who's asking, Deborah, is I would want to make sure that you yourself have been tested have had blood testing for any genetic predisposition to cancer. Because the reality of genetic testing is that someone has to have the mutation in order to pass it on to their children. So if you don't have a mutation that we can find in your blood, then you cannot pass that specific mutation on to your children, because we don't know it and we can't detect it. So we want to know, has the person who has been diagnosed with cancer first, have they been tested for these mutations? And then if they have been tested for the mutations, then those children need to be tested because they're at risk. Now, 15 is very young to undergo testing, but we usually address this when younger people become adults. So at age 18, we counsel patients that they should see a genetic counselor and get tested. And this is particularly important for adult women who are considering having children. They would obviously get genetic testing prior to going through pregnancy and getting tested. So that usually around 18 is when we start to test people for these genetic mutations.
So typically the screening that we have in some of these high-risk clinics, and this is only for patients who have either multiple family members who have pancreatic cancer, even though we don't know what the underlying germline mutation or abnormality may be, or those who carry a particular germline mutation but don't yet have cancer. So that screening, that age for pancreatic cancer, is typically 10 years before the youngest onset pancreatic cancer in the family. So for example, if you have a family where you have 4 family members with pancreatic cancer and the youngest pancreatic cancer developed at 50, the unaffected first-degree relatives who carry the mutation, again, this is very important what Allyson said, if you don't have the mutation, your risk is just like everybody else because that mutation is not there in your blood. But if you carry that mutation, you don't have pancreatic cancer, your screening would begin at about 40 years of age, 10 years before the youngest onset pancreatic cancer. By screening, I mean, sort of the MRIs and endoscopic ultrasounds that Allyson was talking about.
Right, and Letwin just posted information about a screening program that's going on at Hopkins now. I know that in New York, Columbia University has a screening program for pancreatic cancer. Sloan Kettering also has a screening program, and then I also work with a physician in Westchester, Dr. Joshua Rath, who has a screening program for patients who are at high risk for developing pancreatic cancer for the children of the high risk patients. So there are a lot of screening. There are a lot of centers that have these screening studies. So I encourage you to seek this out for your family members if you are known to be at risk for this disease, because we definitely want to consider screening people earlier to try to detect this disease earlier. Anirban, what do you know about that's going on with the like, how close are we to getting a blood test for this?
I mean, I think, optimistically speaking, I would say 5 years. And the reason for that is simply because, again, what I mentioned previously, you need to do multiple layers of testing for it to be at a point where you can reliably say, yes, this person does not have the disease, or yes, this person has enough of a suspicion for the disease to now undergo all of these expensive testings. And so it will take us a few years to get there, but that effort is seriously underway right now through all of these, sort of bake-off studies that I was talking about. Which did not happen before, to be honest with you. Everybody was sort of working in their own silos and doing their own studies and publishing. But now there's this national effort to sort of put all of these biomarkers against each other and find the best ones. So optimistically speaking, I think in 5 years, we'll have something that looks promising. By promising, I mean, not just a single institution study, but something that has made it past multiple layers of testing. And then hopefully we'll get to the point where we can go to the FDA and say, now we want to have this as an official test for pancreatic cancer. Right. The other thing I just wanted to quickly mention is, one question that we often get is, if you have one family member with pancreatic cancer, should you worry about getting tested? So just one family member who has developed pancreatic cancer in an elderly age, yes, there is a marginally high risk, but it's not enough to the point where you need to start worrying. I mean, do the usual things, don't smoke, have, healthy life, all that, exercise, all the stuff, but you don't need to enter a screening program. In fact, most screening programs will not accept individuals who just have had one family member, especially if this is not, young onset disease or where there's been a mutation that's been found. If there's a mutation found, that's a whole different ball game, because then, obviously it increases your personal risk. But if this is just a, individual who unfortunately by chance had a family member who had pancreatic cancer, yes, of course, you always worry about your own risk, your children's risk, if you're a parent, or your siblings' risk. But it is not something that, should worry your head off, because it really is something where the risk is just marginal at most, and it's not something that requires the kind of screening that true high-risk populations would need.
Right. And we're about to close up soon, but I just want to address one last issue, because this is a hot topic now. Sure. And it relates to immunotherapy, but it also relates to genetics. So there is an entity called Lynch syndrome, yes. Which is a hereditary GI cancer syndrome. So patients that have Lynch syndrome can get colon cancer, can get pancreatic cancer, can get stomach cancer. And the hallmark of Lynch syndrome in terms of the cells is something called MSI high cells. And those MSI high cells are cancer cells that would respond very well to immunotherapy. So in addition to finding out if a patient has Lynch syndrome or a Lynch-related cancer, it's important to test patients for MSI high in their cancer, because they may be eligible to treat the cancer with immunotherapy. Now, this only applies, unfortunately, to a very, very small percentage of patients with MSI high cancers. It's, I think, about 4 or 5% of cancers are MSI high. It's a small percentage. However, there's now very, very effective immunotherapy treatments that have been approved to treat this. So one of the things we also test for in our patients, in addition to taking a good family history, is also testing for this protein called MSI in cancers. I think we should start wrapping up because we only have 2 minutes left. I just want to summarize a little bit about what we talked about, and then I'll leave the closing remarks to Anirban. So we mentioned risk factors for pancreatic cancer being family history, being smoking, being diabetes, chronic pancreatitis, pancreatic cysts. Those are the most common risk factors. And I also want to point out that African Americans as an ethnic group have higher rates of pancreatic cancer than do any other ethnic group. So they're at higher risk. So all of those are the populations that are at high risk. We do not yet have a screening test for pancreatic cancer for early detection. It is currently in the works. It is being researched very heavily, and we are soon to have a breakthrough in early detection for this disease. And that will be an exciting new development in the disease. It is important to go to a genetic counselor if you do have any of these risk factors for pancreatic cancer, so that you can get blood testing done and also tumor testing done. The oncologist can perform tumor testing, and it's important for diagnosis and for screening of children and siblings, but it's also important for treatment recommendations for the cancer itself. And I'm going to turn it over to Anirban to summarize some other thoughts.
So thank you so much, Allyson. First of all, thanks to everyone who joined in. And again, I just want to emphasize that early detection does have an impact in terms of survival. And that's one of the reasons why both the National Cancer Institute as well as the foundations that are out there are investing in this. I'm confident that as a community, as a research community, we will get to the point in the next few years where we will have something really promising that can actually be used for clinical decision making. On your part, it's the most important thing is awareness, awareness of what potential symptoms might be that could worry you, but also of what we consider promising links. For example, new onset diabetes that is looking funny, behaving funny, that could be a harbinger of pancreatic cancer. These are links that yet is not very well known in the primary care community, but again, awareness is going to be key. And then, keep up with developments in this field. I think Let's Win has a wonderful page that you can come to on a regular basis, and we'll put advances on there. And then hopefully once we get to more concrete tests, we'll be able to use that more widely, initially in the high-risk population, but eventually to everyone at large.
Wonderful. And thank you, everybody who attended today. We will take the time to answer specific questions that came up that weren't covered in the broadcast. And thank you again for tuning in. And we will let you know about our next Facebook Live broadcast. And everyone have a good evening. Thank you.
Thanks. Bye.
Bye-bye.